Okay, I didn't move as much as I normally do because I don't want my hair to sweat out. Okay. All right. So, my task here today is to do the Dementia 101 because more than 30% of us in this audience, and I think Cornelia alluded to it earlier. If she didn't, I'm going to let you know. So, everybody who hasn't necessarily been to one of our programs is really aware of why we do this and how we do this. And it's all about helping you age healthfully, yes. And as you age healthfully, you want your brain to age right along with you such that it's functional, right? Okay, we do talk about Alzheimer's at some point, but the idea is for you to stay healthy. So for those people, and it may be a little repetition for some, but for everybody else, it's like brand new information. So we're going to do a very brief brain health, kind of like Dementia 101, what it is not. And as the program progresses with Dr. Golde, with Dr. Marsh and Dr. Samad, and finally with Dr. Gitlin, you will learn a little bit more about how these things may kind of present in your life. But more importantly, you're going to get some information that you can use to take back to your provider or the provider of somebody that you're concerned about. So with that, let's get started. But before I do that, I'm saying thank you and all this. I want to say thank you to all of you for registering to volunteer to come to our 25th Brain Health Forum. Cheer. We're going to be doing this again in April 9th. So that you don't get your noses out of whack, it's April 9th, Tuesday, April 9th. It's always on a Tuesday, and it's usually between the hours of 10 and 2 because that's what you told us you wanted. So that's why it's between 10 and 2, after rush hour, before rush hour, so you can go pick up your grandkids. Okay, the other piece of this is that we've had a number of long-term volunteers who are with us. You see some ladies in black with purple scarves. Those are ladies from the Atlanta chapter of the Links Incorporated. You'll see them raise their hands. They've been with us for over 12 sessions. Miss Mary over here, she doesn't look her age, and I won't say it. She's been our permanent timekeeper. That's her vested role. But there's some other ladies around here. They're from different sororities: Alpha Kappa Alpha sorority, Delta Sigma Theta sorority, First Congregational Church, the AME Church. And you'll see some gentlemen around here. They're new to the host squad. And those are gentlemen who are actually participants in our research studies. So where are they? They're around here. Where's your hand? Some of you stand up. I want to acknowledge the gentlemen because lots of women participate in research, but not so many men. So next time, and as they want to be more visible, you're going to see more and more men of all different colors helping us to host these programs. So thank you all to all of our long-term volunteers, our short-term volunteers, our permanent staff in the Goizueta Alzheimer's Disease Research Center, and certainly the staff here at the Carter Center who's been entertaining us for the last 13 years. So, Dementia 101. What is dementia? Okay? Before somebody asks me again for the 1,000th time, what's the difference between Alzheimer's and dementia? I'm going to tell you. Dementia is what all the dementias are, okay? Regardless of the type. So under this umbrella term of dementia, there's several different types. There's Alzheimer's, which is the one that's most commonly diagnosed and has been well researched. There's vascular, which has to do with heart disease, cardiovascular disease. So if you've had atrial fibrillation, if you've had high cholesterol, if you've had hypertension, or if you've had a stroke, those are things that make it more likely that there's going to be some brain cells that don't have enough blood flow and they're no longer functional. So that's vascular type of dementia. There's another dementia you're going to hear about called Lewy body, maybe frontotemporal dementia. And there are other dementias, things like dementia that comes from head trauma. We call it chronic traumatic encephalopathy. You get that from getting your head banged, whether it's from boxing, whether it's from domestic violence, whether it's from being a military veteran. And it's popular among athletes, particularly football players. You hear that. There are other types. But the thing that we really are learning now with respect to dementing disorders is that a lot of these dementias don't exist in isolation, which means that you don't necessarily have purely Alzheimer's, purely vascular, or purely anything else. A lot of times they coexist. And because you have different types of dementia, they're caused by different things, and because they have different causes, they're going to be different treatments. You're going to hear about treatments for Alzheimer's today, but Alzheimer's treatments may not be appropriate for vascular disease, may not be appropriate for Lewy body or frontotemporal. So everybody's not a candidate. So what do we know about dementia? This is the big picture. Again, dementia is the broad term. There are several subcategories. Alzheimer's, most commonly diagnosed, Lewy body, vascular, frontotemporal, Huntington's dementia, and I didn't put there it is. On this slide, it's Parkinson's. So if you know somebody who's got Parkinson's disease, they probably also have some problem with the way their brain functions and processes information. So what do we know about Alzheimer's? In 2017 and in 2020, a panel of experts around the country, around the world really, got together to talk about what we think dementia is and what dementia is not. And we've decided that it's a spectrum of disorders that begin not when you're in your 50s and 60s, but way back at the very beginning when you're born. We start this. Okay, so early life, the better educated, the better literate you are, more literate you are, the more likely you are to do things that are more healthful because you can read information and you can apply it to your life. 40% of all dementias have modifiable risk factors. In midlife, these risk factors include things like hearing loss. You heard me talk about traumatic brain injury, hypertension, alcohol. I didn't mention this all together, but chronic alcoholism creates a type of dementia as well, all right? And obesity. You don't have to take notes because you'll get pictures of this. Just want you to sink it in for a minute. Midlife. What's midlife? What's an age for midlife? Somebody shout it out. 45, 50. Good. That's very good. Okay, so you start sowing the seeds for later life dementia when you're in your 40s and your 50s. So that's why this is important for those of you who are less than 65. We call dementia or Alzheimer's that occurs before the age of 65 early onset. After age 65, we call it later onset. So midlife issues, hearing loss. If you're wearing earbuds and you're listening to loud music, you're probably going to develop some hearing loss over time. Okay, hypertension, a 20-year history of hypertension is associated with Alzheimer's. So what other things on this list? See the little purple block? Smoking, depression, social isolation, staying socially engaged is something that helps your brain. Being physically active is something that helps your brain. We've learned now with some of the research that people who have been born and exposed to a high level of air pollution throughout their lives are at greater risk for developing a dementing disorder. And then I have diabetes down here. Diabetes and hypertension are some of the major risk factors for heart disease, but they're also major risk factors for Alzheimer's and related dementias. So how do we diagnose Alzheimer's? You know, do you just go to your doctor's office and they give you a 10-minute test and they tell you have dementia? No, it's a process. So for anybody who wants an instantaneous diagnosis of dementia, I'm sure I can find a number of phone numbers on Google where you can go to get a diagnosis for a price. It won't be accurate, but we'll get you something, okay? We can find that for you. I won't find it, but you can find it. So dementing diagnoses, it's a process. It's not an instantaneous thing. We've gotten a little bit better with it, but you have to start with a comprehensive medical exam that's generally done by your primary care provider. And in this examination, they're going to go over all of your medicines to make sure you're taking the right medicines for the right reasons. And if you have chronic disorders like thyroid disease, diabetes, vitamin deficiencies, we're going to look for that. And on the subject of vitamin deficiencies, we test for that. A vitamin D as in dog deficiency is associated with cognitive dysfunction or memory loss or judgment problems. Okay, but we can test for that and we can treat for that. You don't just need to willy-nilly take stuff over the counter. And before you ask me if Prevagen works, if you believe it works for you, it works for you, but it's really not been proven that it does anything for anybody. Okay? The second thing that your primary care doctor is going to do is order a brain image. Okay, 3 minutes, Miss Mary, I'm going to move. That means you get an MRI of your brain to look for architectural abnormalities. The FDA approved test for looking at your brain for Alzheimer's is an amyloid PET scan. Now I understand it's an FDA approved tool, but Medicare will start to pay for it. And they've started to pay for it because the new therapeutics require that you have a PET scan or cerebrospinal fluid analysis that documents that you actually have Alzheimer's. You need the services of a neuropsychologist. That's a PhD clinical psychologist who does pen and paper tests to help you measure what kinds of brain functions you have or you don't have. Together with that information, we refer you to the neurologist who may do a lumbar puncture to get cerebrospinal fluid. Now, why do we need to stick a needle in your spine and get cerebrospinal fluid? Because right now, that is the main way that you get a diagnosis of Alzheimer's. We analyze your cerebrospinal fluid to see whether you have the accumulated abnormal proteins called A beta and tau proteins, and that gives you your diagnosis. We now have other biomarkers besides cerebrospinal fluid, like blood biomarkers, that we can use, but they're not widely available, nor are they approved by your insurance for payment, but we can get them. Emory's Goizueta Alzheimer's Disease Research Center is one of 37 Alzheimer's research centers in the country. There are 4 exploratory centers. The one closest to here is in Birmingham, Alabama, and another one in Tennessee at Vanderbilt. These are places where you can be evaluated for Alzheimer's and related dementias, but these are also sites in the country where you can be put in a clinical trial of some sort. Okay, 37, we're one of 37. Miss Mary says I have 1 minute. One of the things that we do for diagnosing Alzheimer's is determine biomarkers. These are things that are in your blood, in your sputum, in some of your body fluids that monitor the progress of a disease. Right now, the biomarkers that we're commonly looking at are biomarkers for A beta and tau proteins, which accumulate in Alzheimer's disease. Right now, we do that through cerebrospinal fluid and now through a blood test. Again, that's the thing that's not widely available, but we also do it through radio imaging, and that's the PET scan that I talked about earlier. So this is a lot of reading, and this is the newest criteria for diagnosing Alzheimer's and related diseases. It's not subjective. It's very biologic. It's very chemical. So again, people may have evidence of Alzheimer's but not look like they have dementia. And it's something that has to be determined by your blood and pathology slides. It's an involved process. So in summary, excuse me, I think I have to go back one more. I want you to appreciate that dementia is not normal. Dementia is a many splendored thing. There's a process involved for helping you get a diagnosis. There are new treatments that are not available for everybody, and you're going to hear a little bit more about that as we go along. Research is needed, your participation in research. I don't care what color you are, I don't care what your ethnicity is. We need you in some research. Pick the one you want. And finally, this is my memorial slide to Bishop John Hurst Adams, who is a bishop in the African Methodist Episcopal Church, who is one of our key advocates for making sure that we democratized, and I'm going to use that word, Alzheimer's participation in research, because we need all people to participate in research. With that, I will end. Thank you, Miss Mary. Our next presenter, and you're going to have to sit for this one, is Dr. Todd Golde. He leads our Center for Neurodegenerative Disorders. He's a professor of pharmacology and clinical biology and professor of neurology here at the Goizueta Institute at Emory University. He came to us from Florida, and he's going to talk a little bit more about some of that science that I talked to you about that determines whether or not you have Alzheimer's. Dr. Golde.
Well, thank you, and thank you for your attention. And I'm really delighted to be here because for many years, when I would get up and give a research update, we just offer hope. We couldn't actually offer really good news. So there's some good news here. We finally won a skirmish in our battle against Alzheimer's disease. We are far from winning the war. And what I'd like to do is sort of walk through a little bit about the molecular underpinnings of what causes Alzheimer's disease and how that understanding has led us to therapies that actually do offer some hope for altering the course of this devastating disorder. And then also talk about some of the other advances that we've made and do so in a way that is, sort of, I think, hopefully understandable, and also convey some of why has it taken so long to start. I started doing Alzheimer's research as an MD PhD student in 1986, and I was fortunate enough to be involved in some of the seminal studies that sort of told us what was going wrong with the brain in the early 1990s. Yet finally now in the 3 decades later, we're finally seeing the fruits of those labors. And really, I think it came from, and I'll try to explain this, that Alzheimer's is a much more complex disease than we envisioned back then. But it's also been that it's a long journey from getting these underlying pathologies to actually getting symptomatic disease. And trying to intervene in these stages when you're already symptomatic is, I think, part of the challenge. And ultimately, I think we're going to have the best public health impact by getting to prevention, but it's not a straightforward road to get there. So Dr. Parker talked a little bit about this, but basically when Dr. Alzheimer's back in 1907 and 8 described this disease from an autopsy of a brain, he described 2 pathologies that you'll hear about, this amyloid plaques, I think I'll show them on the next slide, and this tau pathology, as well as neurodegeneration. And it was in a patient who had died in her 50s and actually turned out to have probably a genetic form of Alzheimer's disease. But until very recently, we had to actually do the same thing. We had to get a brain from somebody who had died and look at it from a neuropathological perspective to actually make a true diagnosis of Alzheimer's disease. And one of the amazing advances that has happened over the last 2 decades is that we can now diagnose Alzheimer's disease with certainty in living patients using a variety of biomarkers as well as cognitive tests. And what we know is it's a long journey. Those pathologies and changes in your brain begin 20 to 30 years before you show cognitive symptoms. And through a variety of tests, and that's just shown on the right, and it's not really important, but amyloid protein changes first, followed then by some other markers, but eventually this protein called tau changes, and then eventually you show cognitive impairment. But that is a 20+ year journey. And so it means that the underlying pathologies of Alzheimer's are beginning long before. And in truth, I'm showing on the plaques are these little extracellular lesions. They're composed of this protein called A-beta. They're shown up there on the, I guess it's your left of the slide, and then the tau pathology, and then you have brain shrinkage as well. But it's also clear, we know some of the negative risk factors for Alzheimer's disease are educational attainment and high IQ. So the idea that Alzheimer's only happens when you're late in life is really not true. You're being set up for it either by your genetics, various other factors in terms of brain development. Dr. Parker also talked about all the things that happen in midlife with hypertension, diabetes, obesity that are also risk factors. And then what's important is that once you start to have that underlying pathology of Alzheimer's disease, in most people, not in some of these early onset genetic forms, but in most people, it's occurring in the setting of advanced age, where many other things we'll hear about, vascular impacts, and other diseases and disorders can impart this. So what we've learned now, and we begin to see this as we explore this disease more, is it's much more complex than just these plaques and tangles. Yet they are the core features of the disease. So new therapies. This is where I think we could be hopeful. They're monoclonal antibodies. You might have, so this is something your body normally makes, but we can actually take one of these out, find one that has a certain property. In this case, it's the ability to blind these amyloid plaques. We think they work by actually binding the plaques and then activating immune cells in the brain to clear it. But unfortunately, this also happens in vessels, and that is probably good and bad because it's probably related to some of the side effects. But shown below is somebody who's got a scan of the brain, and the bright colors are the amyloid that's being visualized. And after treatment with one of these antibodies, one could see that that signal is reducing. So this is what's called a disease-modifying therapy because it's targeting one of the core underlying pathologies. So what happens clinically? Well, in many of these studies, and this is an example of donanemab data, you'll hear probably some data from about one of the other ones called lecanemab. They have all these crazy names, but these are not cures in symptomatic patients. They're simply slowing cognitive decline on average somewhere between 20 and 30%. But one of the interesting things we've learned is there's a right time for these drugs to be initiated, because if you have less pathology, you're still cognitively impaired slightly. So in the very earliest stages of cognitive impairment, these drugs seem to slow on average cognitive decline by 20 to 30%. But if you include people in those trials who have a little more pathology, so these are people with high amyloid and high tau, then that effect is a little less. So it suggests, as we predicted, that the earlier you go with these treatments, and now it's being tested in people who are asymptomatic, people who have amyloid in their brain, but before they show symptoms, we think their impact will be bigger. But that's something we still don't know. And again, many questions remain. There are serious side effects in these trials. These relate to hemorrhage and brain edema. They're rare, but these were highly controlled studies in these trials. And when we go into real world populations and more diverse populations, we don't know how that it's going to affect. So, a 20 to 30% slowing of cognitive decline is certainly better than nothing, but it's still just a start. And what we don't know, for example, is if we treat people with this, there's some people, like in a cancer study, where instead of prolonging survival by a little bit, we actually cure people. Are there people who have, maintain their cognition for much, much longer than expected, or avoid going to a assisted living facility for earlier times? And, we also don't know, these studies ended at 18 months, although many of these people are still being followed. But is the effect durable? If all you get from a pretty intensive therapy is 20 or 30% and then no real more benefit, that's going to be a hard decision for people to make. And again, this is going to have to be a decision that's made in conjunction with your provider after some long, serious discussions and whether or not somebody meets the criteria for using these drugs. Further, these are antibody infusions. They require a lot of testing. They're pretty onerous drugs to take. And so how do we make these drugs or similar next generation drugs more accessible, less costly, and less burdensome for those undergoing treatments? And again, this idea, my own hope is that we know that amyloid, or I think the scientific evidence suggests very strongly that this is the trigger of the disease. The earlier you go, the bigger the impact is. And we can now diagnose people or know that they have the underlying pathologies long before they show any symptoms. And one of the things that's very germane to this audience is in these trials, we were horrible, the medical field, and it's just, needs to be stated, the diversity of the populations being studied in those trials was not representative of our real world populations. And so we need to do much better on including people in these trials. Again, they're onerous trials, and to know, does it work in a highly educated, Caucasian individual, the same as it works in, somebody from an underrepresented social group with, who's not Caucasian. And we actually don't know that right now. And so we need your participation to help figure that out. And again, this is sort of a very complex slide, but it's just showing this sort of long history, and we're going to bring out other drugs that hit other areas in the cascade of Alzheimer's disease pathology. But it was actually sort of lucky that in the symptomatic phase, targeting this initiating protein worked, and that's shown in the yellow bar. We think if we go earlier, before symptoms, that the green bar is saying, yeah, good, that should work and actually prevent people from getting Alzheimer's disease. But we know if you're too far in this pathology, these drugs are not likely to work and will probably not work the risk. So another one, this tau pathology, again, we could image this in the living brain. That's shown with the red arrows here. And so before treatment, you could see this red area is where the tau pathology is. And so there's another drug emerging, and this is just an example. These are very early data. We have no real impacts on cognition or anything from this very small trial. But this is basically showing that we could actually target the tau pathology. And so again, we're in a really exciting era for the field where we're actually able to modify the pathologies underlying Alzheimer's disease, and we hope that that leads to clinical impacts. Dr. Parker talked about biomarkers, and so biomarker, I simply sum up what a biomarker is, something we can measure as a sign of health or disease. And again, we now have, I mentioned some of these, but by imaging, we could study the amyloid pathology, we could study neurodegeneration using a magnetic resonance image scan, and we could actually image the tau pathology. And when I grew up in the field, as I said, you had to die before we really knew you had a definitive diagnosis of Alzheimer's disease. And not only can we begin to use these to say, hey, you have risk, but we could probably place you in this 30-year continuum of where you are. And soon we'll be able to say, hey, you're at risk to get Alzheimer's disease in 10 or 15 years. That's a little bit of a forward-looking statement, but I think we're going to get there. Not everybody could, these scans are expensive, they require special machinery, not everybody could have access to them. But we can now also do similar studies using cerebrospinal fluid, and these, again, look at the core pathologies, but they could also look at much more. And this was just a study that came out of Emory, and it's, again, a complicated slide. But it's showing that there's a whole series of biomarkers that you could detect sometimes 30 years before the earliest onset of symptoms. And this actually was based on looking at people who had genetic forms of Alzheimer's disease, and we think it will port over to people with more typical late onset Alzheimer's disease. But again, this will be invaluable not only in being able to derive the early detection of Alzheimer's disease, but also in the development of the next generation of drugs that we hope will be even more effective than what we've just seen. And indeed, the idea is that perhaps with a simple blood test, and again, this is new data, this is unpublished from my colleagues at Emory, that suggest we could see hundreds of biomarker proteins changing in the blood of individuals with Alzheimer's disease. And really, I think we will be able to do, much like you go in and get your cholesterol checked, we'll be able to sort of get a risk assessment as you move forward and say, hey, we have many therapies that we can begin to use to alter the trajectory of you on an individual basis. So from this, I think there are many lessons that we've learned. One is, I don't think we would have approved drugs for Alzheimer's disease that are disease modifying without these biomarker developments. So it's really, despite the increased cost in trials, their use is requisite. And it's participation of people like you who have donated your CSF, your plasma, and undergone cognitive testing that's enabled those advances. Further, in some of the earlier trials where we didn't have those biomarkers, we were exposing people to unnecessary risk. We were targeting a pathology that may not have existed in those people. And so I think it's almost unethical not to use these to say, hey, if you're going to enter into a trial and we're targeting amyloid beta peptide and you don't have it, we shouldn't be doing these. The other thing that I think is really exciting is one of the challenges in our field is these trials cost a huge amount of money. We're talking $500 million, $1 billion for a single drug to move through the different phases of trials for Alzheimer's disease. That's what the price tag has been, and that's why we need our private sector partners, because this is hard to fund for individual agents. But we may be able to reduce this using biomarkers to say, hey, I've got a new drug, I think it might be better, and maybe we could take a much smaller number of people and actually using these biomarkers establish the potential of this drug. And so the other thing, though, is that a lot of the data, again, on these biomarkers has come from study of Caucasians of Northern European descent. And we still have gaps in our knowledge regarding how these biomarkers and their natural history progresses in more diverse populations. And so there's still work for us to do. So I'm optimistic for future success because we've now won, as I said, a battle. We have drugs that could change the course of this disease, but they're not panaceas. So this is, again, a complex slide, but just to say there are lots of drugs moving through that are targeting different aspects of Alzheimer's disease, including just trying to make your symptoms better again. We also know that using these same methodologies that enable us to get us insights into biomarkers and showing how complex they are, that the pathology of Alzheimer's disease is a lot more complex than just A beta and tau. And in fact, I'm showing you pictures of plaques on the right-hand side here. And it doesn't really matter what the names of these are, but these are all additional proteins that are co-accumulating in the brain as you develop Alzheimer's disease. And I wouldn't have even predicted this 10 years ago. And this has come partly from my moving to Emory and collaborating with some of their world-class experts in proteomics here. And we're bringing complementary techniques. But again, we need more shots on the goal. We're not there yet. We need more drugs that are more effective. And I think these early clinical successes will enable us to do that as a field. Finally, I think that I used to get up and talk about the fact that in the early 2000s, AIDS research was funded at about $3 billion a year. It affected about 1 million Americans. And at that time, Alzheimer's disease was, I think, funded around $300 to $400 million and affected, 3.5 million Americans. So thanks to many people, including some of you who have perhaps advocated for this, public awareness and public policy have increased the awareness about this disease, the fact that it's not an inevitable consequence of aging. You could live into your 90s with perfectly intact cognition. And that awareness, engagement has led to action and funding. In fact, it's like a 6-fold increase in national funding for Alzheimer's disease. And that has in part underlied our success. But we still have work to do. I remember I was in medical school during my clerkships when Magic Johnson was diagnosed with HIV. Remember, we barely even knew about HIV. Magic Johnson's still alive today. But Dr. Ronald Reagan was diagnosed with Alzheimer's disease in 1994. As I told you, he had the pathologies long before then. So we still have work to do. Ronald Reagan died of Alzheimer's disease. We still don't have a survivor of Alzheimer's. So until that day comes, we need more research and more efforts. And so I just will conclude by saying we still need your help, support, and participation to ensure that together we transform Alzheimer's disease into a truly treatable, preventable, and curable disease. We're winning the battle, but we're not there yet. Or we won a battle, we haven't won the war.
Okay. We've got a couple of questions, and I'm going to try to get some of these questions answered before Dr. Marsh comes up here, because she's going to talk about vascular dementia, to some degree, stroke and rehab, because we get a lot of that before. So let me pass some of these questions to Dr. Golde, and he and I both will answer some of these questions. We've got 5 minutes, right, Miss Mary?
I could target this one. So role of inflammation in the development of dementia. So your brain has an immune response, and there's signs of inflammation in the brain. But for many years, there was dogma in the field that, dampening that inflammation would be good. And the genetic studies have told us that it may actually be the opposite. And so there are drugs targeting the inflammatory pathways. And since we don't have a true model of this disease, except for Alzheimer's, the human condition, we'll just have to wait the results of the trials of these drugs that are now targeting in very specific ways the brain immune cells, and we'll see whether they have efficacy or not. But it is a hallmark of the disease, but its role is complex, like it is in many, many settings, and whether we could target it in a way that will lead to clinical efficacy remains an open question.
I'm going to answer a question on how do I find a memory care doctor prior to developing dementia. This is where it's important for you to establish a good relationship with your primary care doctor. If you have some subjective, which means you think you're having a problem, you need to discuss that with your primary care provider so that they can make the proper referrals and order the right tests, let's say, such that you can start your evaluation. If there are some genetics and other things, you say there's a high incidence in my family, if you've learned in the last 20 minutes or so that there are some genetics that are associated with it, but there are different types of dementia, and that's why you need to start with your primary care doctor. Okay.
I think this is an important one. Does insurance cover biomarker testing? So actually there was just some news that the imaging studies now are going to be covered by insurance. I think, this is a rapidly evolving field, and it's hard to stay abreast of it, but I think we will over time, especially with the need for these biomarkers to underlie whether you get a approved drug or not. We'll see more and more of these being accepted and paid for by insurance, but it changes almost monthly.
And that's true. Okay, I'm going to have a question here. One of them I'm going to save for Dr. Marsh. It says, for people who have difficulty sleeping and sleep apnea has been ruled out, do you have a recommendation for a sleep medication that does not increase the risk of dementia? I think, again, that's something that you discuss with your provider. Depending upon your age, there are some medications that are appropriate for those of us who are over 65 and some medications that are not. One of the things I do want you not to do is take Benadryl. How many of you take Benadryl? Okay, for those of us who are over 65, Benadryl can make it such that you have dry mucous membranes, you get more congested, you develop constipation. For men, it makes it more likely that you're going to have difficulty passing your urine. So you don't want to take Benadryl when you're over 65 to go to sleep. Go see your doctor, get a sleep evaluation if that's necessary, and discuss with your doctor the best option for helping you to get to sleep. You don't necessarily need to take Ambien.
I'm going to combine a couple questions around what does brain shrinkage mean, and can the brain atrophy or be repaired? And the answer is, in most cases, we think brain atrophy is associated with clinical symptoms. The areas of the brain that shrink are often the areas of the brain that we know are responsible, for example, memory formation, and so that there's a good correlation there. There are some odd things in some of the clinical trials where we see actually some of the treatments result in some accelerated brain shrinkage, and that gives us some pause, but that ultimately the clinical improvement is what's important. But I think that this gets at the question of, we don't just want to halt or slow cognitive decline. We actually want to either halt it or even potentially reverse it. And that's a lofty goal, but I think armed with new insights and in the future, we may be able to do that. I won't guarantee that. I don't want to put a timeline on, but it is what ultimately we want to be able to do.
Okay, I think that, okay, I have to stop, and we'll get some of these a little bit later and we'll get to them. At this time, Dr. Golde and I are going to leave the stage, and Dr. Elisabeth Marsh from Johns Hopkins is going to come up and talk to us about vascular dementia and rehabilitation strategies.
Great. Well, it's an absolute pleasure to be here today. Like Dr. Parker said, we're going to shift gears just a little bit, and we're going to move from talking about Alzheimer's disease to talking a little bit more about vascular dementia, and specifically about stroke. And I'm going to tell you a little bit about stroke, and you might say, why is she talking so much about stroke? I have never had a stroke, but I think it does two things. One, unfortunately, stroke is incredibly common as we get older, and that's because all of the risk factors, diabetes, hypertension, atrial fibrillation, get more and more common as we age. And two, a lot of what we can learn from the cognitive impairment that comes after stroke and the effect it has on cognitive networks, we can apply to vascular dementia and to the aging brain, and it can help inform how we treat these diseases moving forward. Stroke's really exciting. We've come a long way from back in the 1990s or early 2000s, when unfortunately people would just come into the hospital with a stroke and then they'd be stabilized and then admitted to rehab, where they'd work on getting better if they couldn't speak or couldn't move. Now we have actual treatments. If you come in and your blood vessel's blocked, we can actually pull the clot out and make you better, faster, get you walking again, get you home with your families. It's pretty remarkable. You can see here, this is what stroke used to look like. So this is a brain, and this is a huge stroke, this right area, this white area. It's on the left side of the brain, so this person couldn't talk and they couldn't move, and they were bedbound or had to be in a wheelchair, and their family had to care for them. That same person, if we take that clot out, if they get to the hospital in time, can have this tiny little stroke instead, where they're talking and they're moving and they're doing really well. It's a major advancement, and we're super excited about it. I think it's really important, and it's a great step forward for the field. But with any change, you have unintended consequences. And what I found in my clinic is that while patients were doing a lot better after stroke, they had these other issues that before they didn't complain of. Before, when I'd see people, they were concerned about the fact they couldn't talk or they couldn't move. But now they were doing those things, but they were saying, I can't think. I used to be the epitome of multitasking, right? I could manage my 5 kids and my job and my husband and take care of all these things. And now I have to be talking directly to the person, or I get confused. I just don't care. I don't have any memory. What's going on? I thought you said my stroke was little. How come I feel this way? Right? And I said, well, that's a really great question. I'm not sure why you feel this way, right? What's going on? So first, what we did is we wanted to take a look and say, how many people is this actually affecting? And when we looked at our stroke population, we gave them a test that some of you may be all too familiar with, right? It's called the MoCA, the Montreal Cognitive Assessment. And it asks you to do things like connect 1 to A to 2 to B, or draw, I was never very good at drawing, or draw a clock, or name some funny animals, and you get points for being correct. And on average, people should get a 26 or more, no matter how old they are. And what we found is that after stroke, average people, 2/3 of them were scoring below that 26 cutoff. Now you may say, okay, people are different, but 2/3 of the population, right? That's a lot of people. And almost a quarter were scoring severely cognitively impaired, right, on this screen. So what's going on? When we looked further and actually compared a large group to controls, we found that it wasn't just in one domain of cognition. So it wasn't just that their memory was affected or just that their language was problematic, but all of their cognitive domains were affected. If the average is here, everybody after these small strokes was functioning below the average. And it was really impairing how they were able to go back to work, go back home, interact with their families, and how they felt about themselves. Right? We learned some important things even with that initial study. We learned that, okay, size does matter. I'm not standing up here telling you that the little strokes do worse than the big strokes. Of course, if you have more of an area that's damaged, you're not going to do as well. That makes sense. But what really surprised us, and I think one of the first lessons that I want you guys to take away from all this, is one of the big things that kind of made a difference in how people did was whether or not they were actively employed prior to their stroke. Whether they were out there, whether they were functioning, whether they were doing something with their brain and using their brains. And the people that were actively employed did a lot better on their MOCAs. They didn't have that same decrease that we saw with others. In other words, baseline really matters. So how you're taking care of yourself now before something happens to you in the future is really important. And taking care of the brain to ensure that it has reserve so that if something does happen, you wind up better is really important and something we don't always think about, especially not in our 40s or our 50s or even our 60s, right? So from the stroke patients, one of the other things that we really began to think about is, what does stroke tell us about patients with vascular dementia or cognitive impairment in general? Right? I told you that that small stroke caused people to have trouble thinking, trouble with memory, trouble with language. We teach our medical students that in the brain, one area is responsible for one thing, right? You damage this part and you can't talk. You damage this part and you can't move. Yet these people had tiny little strokes all over their brain and they all couldn't think. They had problems. What's going on? And can we use that to make people better? Well, I'll tell you that our theory is that it doesn't matter where you put a little stroke in the brain. In reality, I hate to say it, medical students, but you actually use your whole brain to do everything, right? In order to think and in order to do a task, it's not just one area that's important. The brain has to communicate from here to here to here to here and back over and over again on a millisecond level. And the thought is that if you put a stroke anywhere in here, that communication can't happen, right? It's slow. It's not working right. No wonder people feel fuzzy. Well, it's good to have a theory, but you got to prove it first, right? And then figure out how to fix it. So what we did, this is my nurse practitioner, Dawn. She hates when I show this picture, so don't tell her. We started to collaborate with a team at the University of Maryland in College Park that has something called a magnetoencephalography. I don't know, physicians like to have really long titles for things, but you can call it a MEG, an MEG. And what it is it's a tube. It looks a little bit like an MRI, but what it does is it lets us look at brain activity in real time on a millisecond level. So when you're trying to think of a task, we can measure and see exactly what's going on in your brain and how that's different than somebody either that doesn't have a stroke or doesn't have dementia. I'm not sure if this is going to work, but it doesn't look like it. Well, so what you'd normally see is if you were looking at a beam of light, you'd see some activity start here in the back of the brain, and then it would grow and it would encompass this area and then, here we go, and then larger areas. Do you see how fast that is? I want to draw your attention. This is on the millisecond. This is 80 milliseconds, right? That passed a long time ago. So we can really see what activity is like in and out of the brain on these scans. It's pretty cool. So again, all of the people that we started looking at in our study to look at connectivity had strokes that looked like this. So not those big whiteouts that I showed you to begin with, but everybody felt slow and they felt like they couldn't remember and they felt like they couldn't multitask. And they couldn't. When we did the cognitive batteries, they weren't crazy. They really couldn't do it. They were well below average. So we put them through a task where they'd see these two pictures and then they'd get the name of a picture. And they had two buttons and they had to decide which one the picture matched with as fast as they could, right? So we were timing them. Remember, they said they were slow. And I want you, in order to take a look at this data, to keep in mind that in order to process information, you have to have an area of the brain and information has to reach it, and you get this really nice downward deflection, or sometimes it's an upward deflection, but it's nice and sharp, and then it repolarizes. And it's something called the M170 response. So if you're looking at a picture, we see this M170 response on the MEG. And that's what normal people who are doing things quickly are able to generate in the brain. When you have signal, right? Signal going down a wire or going through the brain, going down neurons, what happens is the information has to travel, and it has to travel really fast. So it will travel, and all the signals will travel together. And when they all travel together, they summate and they create this nice big signal. But if you have a hole and information can't get through and it has to go around, then all of a sudden it's not traveling together anymore. And some of it reaches a lot earlier than others. And what happens is you get this delay, and it looks a little bit more like a rolling hill. So we want to have these nice sharp mountains, and we don't want to have these rolling hills. This is dysfunctional connectivity. So what we found when we put controls in black versus patients in blue through the MEG and had them do this task is that the controls had nice sharp peaks at the M170 responses. And the stroke patients, as expected, had these rolling hills, because rather than information traveling all together through their cognitive circuits, some of it got delayed. And that was leading them to feel slow and to not process information in the same way. One of the other things that we were able to look at is actually direct connectivity. So how does this neuron here communicate with this neuron here and tell it what's going on? And how does it do it? Does it do it fast enough? Are there enough of these neurons to tell these what to do? What's that look like? So what we were able to do in the stroke patients is we were able to look and compare them to controls. So this control initially has a ton of connectivity, connections between both sides of their brain when they're doing the task. The right talks to the left, the right talks to the right. There's a lot of communication as they're thinking and trying to do the task. And that stays at the 6-month time period. That makes sense. There's nothing new with that person. They didn't have a stroke. It looks the same. Look at the stroke patients. Right after their stroke, a couple of weeks later, what do you notice? They don't have very good connectivity at all, right? There's not much crosstalk at all between the two sides of the brain. Right? At 6 months, when a lot of people are a lot better, that's improved pretty significantly. It looks a lot more like the controls. Looking at it a different way, you can see that initially the stroke patients, a couple of weeks out, have a lot of activity on the opposite side, the contralesional hemisphere, the side they didn't have their stroke on. But by 6 months, the two sides are talking again. And that's what happens in a person's brain that hasn't had a stroke. But what was really cool and what we were really able to do was not only predict how people were going to recover, but we could tell what happened after that, whether they were going to go on to continue to improve or whether they were going to decline. So the patterns that we were seeing in the brain actually told us what was going to happen in the long term. And that's important because not everybody gets better long term after a stroke. I tell patients that almost everybody is better at 6 months than they are initially. That makes sense, right? But unfortunately, there's a group of people, and we don't yet really understand why, who go on in at year 1 or year 2 or year 3. Maybe the brain tires out. Maybe it just can't compensate anymore. But they actually will go on to get a little bit worse. And the whole question is what's going on there? How are the cognitive networks affected, and can we do something about it? So I told you that there's cognitive impairment after stroke, and that's really important. But I also told you that I believe there's a link with vascular dementia. So what do you guys notice between this little stroke here and a person with vascular dementia's brain? Can I convince you that a lot of this is probably just a lot of these summated over time, right? So one of the theories of vascular dementia is it's this accumulation of these tiny little infarcts. And if I told you that one tiny little infarct can mess up the way the brain talks to itself, then imagine what a bunch of these tiny little infarcts will do, right? That's why it's so important, and you've heard so much about those vascular risk factors when you're 40 and 50 and 60. It's no fun to think about cutting out salt and being on a blood pressure medicine, but that's really the great time to make sure that these areas of damage don't accumulate in your brain, because they really are hurting it. So I want to end the talk on an upbeat note. So thinking about ways that we think, thinking about what we've learned and things that we may be able to do to help, right? So what has the stroke population taught us that we may be able to apply to the vascular dementia population, right? How can we take those cognitive networks I was telling you about, and how can we get them better? Well, there's a couple things we can do. We can do some traditional things like focusing on rehab. Unfortunately, for a lot of high-functioning people, when they just have some mild impairment, rehab can be difficult because they look pretty good, right? So a lot of times what I'll say to patients is find something that you're bad at, find something that you're struggling with, and that's what I want you to work on, right? Because there's an attainable goal. The most important thing is to exercise the brain, to use it. It's like anything else in the body, right? Use it or lose it. If you don't go to the gym and you're not moving, right, you're gonna sit down and then it's harder to get up. If you're not using the brain, doesn't matter what the activity is, it needs to be a little bit challenging, right? But if you're not using the brain, it also starts to not work quite as well. So that's really important. But other things might be able to stimulate the network too, right? So we have a lot of these little molecules, these drugs that are called stimulants that kind of rev things up. Maybe some of those will help the cognitive networks. But there's some non-traditional treatments also. And I want to tell you just in the last few minutes of this talk a little bit about what we're doing with some of those. So the first is something called mindfulness, mindfulness-based stress reduction. So mindfulness is actually a practice that dates back to ancient times. It was adapted by the Harvard group, and they put together an 8-week course where they combine meditation and yoga, right? So body movement as well as meditation of the brain. And it's actually been used and studied quite heavily in patients with all kinds of chronic disease states, so diabetes, migraine, and even one small study in Alzheimer's. What I like about mindfulness is that if you think about the Buddhist monks, when they put an EEG on the Buddhist monks, they actually found that following meditation, and these guys were experts, right? So good meditation, you could see changes in the temporal lobes. It's almost like it's exercising the brain. So the thought was, well, if mindfulness is exercising the brain and we need these cognitive circuits to work, maybe it'll work for stroke patients. Maybe it'll work for vascular dementia patients. So we designed a study and we just closed, so stay tuned for further details, but we enrolled 30 patients and we randomized half of them to mindfulness, and they underwent the 8-week course and they practiced. And the other half went to a stroke support group because we wanted that interaction. Remember, I told you all interaction is good for your brain. Doing something is much better than doing nothing. But we wanted to know if the mindfulness piece of it got even more benefit. And what we did is we put people in the MEG scanner to look at their brain connectivity before and then following therapy. And we also did fairly extensive cognitive testing to see whether exercising the brain with mindfulness improved those cognitive circuits and helped people to recover better and to stay improved than the stroke support group. We're in the middle of analyzing data. I was hoping to have some for you. I will tell you that anecdotally, people felt like they did better, but the data is going to be what's really important moving forward. There's some other things we can do. So there's something called neurostimulation or TDCS, where you put little electrodes on the brain. I tell my residents about the 9-volt batteries and they look at me like I'm silly, but I don't know if you've ever had a 9-volt battery and my dad would ask me, is there juice in the battery, right? To stick it on your tongue and see if it zings. Okay, at least you guys know what I'm talking about. My residents look at me like I'm ridiculous. So that little bit of current, even less current, is what goes through the stimulation. So it's a tiny amount of current, not dangerous at all. But what it does is it targets this part of the brain and it stimulates. And I'll tell you, you can put it anywhere in the brain and stimulate different circuits. So doesn't this look a lot like this circuit, which is one that we've been trying to target for cognition? There's some really good data with neurostimulation and language, as well as with motor recovery. And we're hoping that by having targets that we can actually go after and then show through MEG that we've actually engaged those targets, that we're going to be successful and that we're going to be able to, again, help people get better and get better faster. So I just want to end by saying that, you know, a lot of this work has been done as a team, and you'll hear that that people are really interested in brain health, and it's really incredibly important, both at the preventative level, but also at really understanding the pathophysiology, because that's what's going to be able to help drive the treatments. And all that you're going to hear today about the Alzheimer's literature and the new antibodies, as well as some of these strategies, are all based on really understanding what's going on at that level. So I'm really excited for the future as we get to know more and understand more, and I welcome hearing from you, your thoughts and discussion. With that, I'll thank you.
So we've got a couple more questions, and I know this is going to be the last question and answer session before we have our break, our stretch break, and then we'll go with the last half of the program. So if you need more cards, we'll pass some more out, but there are a couple of questions, and I'm going to start this one off. Alzheimer's and diabetes. Can you talk about diabetes and its risk relationship to stroke, Dr. Marsh, please?
Sure. So diabetes is a huge risk factor for stroke. So managing someone's diabetes and really getting their sugar under control can make a huge difference. And what we also know is that when patients have stroke and they have diabetes, that often that can complicate their outcomes, often because diabetes leads to other chronic medical problems, right? Like neuropathy and vision changes that can affect your function. So really making sure to get your diabetes under control with your primary care physician, the best that you can, will really have a significant impact both on your stroke risk and on your overall health.
There were a couple questions around participation in medical research that I thought would be important to address. One was just, can you be cremated and still donate your brain? And the answer is yes. You could actually have a viewing, and so and still, as I showed you, that without having brains at autopsy, I think we would be lost as a field. So it's still really important. And again, the issue around diversity in our brain banks is a huge problem. And we, especially around having people who didn't have any cognitive problems before they died. The other one was just around disclosure of information and your medical status during trials or when you participate in a research study. And there is a lot of regulatory guidance designed to keep people safe and protect the research participant during these studies. And so it depends on the individual study, what's deemed medically necessary, and that may very well change as new treatments and things emerge. So again, there is a huge amount of regulation for good reason around medical research to protect you as the research participant. So that guidance is there for a reason. And, it's not a perfect system, but it's the best we can do in order to protect you when you participate. And so, again, sometimes it may not be satisfactory because you'd like more information about what people are learning from your brain or the study of you, but ultimately those regulatory guidance have been put in there to protect you.
Great. I'll put a couple of these questions together. So there's some clarification about what different terms mean, whether a small stroke is a TIA. So stroke is kind of a spectrum, and a TIA is actually something when a blood vessel closes, but then it opens before there's any permanent brain damage. So it's kind of like the angina, the chest pain without the heart attack, right? You have the chest pain, but you get to the doctor and they say, oh, I'm so happy to tell you there's no permanent damage. That's what a TIA is. A small stroke, the strokes that I'm talking about, and to someone else's question, sometimes we call them lacunes, which means little lake, so tiny, like that small white spot that you saw compared to the big white area. Those are permanent damage on the brain. Somebody else asked if bleeds were also considered a stroke, and they're hemorrhages, and we think that probably they do similar things. For a lot of the times in the stroke literature, we separate ischemic strokes where there's a blood clot from hemorrhagic strokes where there's a brain bleed in the brain, because with brain bleeds, there's a lot of inflammation and other things that happen that can kind of cloud whether it's just the location or whether it's the bleed itself. So we often will separate them in research. But in theory, right, if you are impacting a location or an area of the brain, similar things should happen. And that is what we see in practice.
There was just another one that was a little along the lines of participation. So for example, if you're being screened for a clinical trial where the inclusion criteria would mean that you have to have amyloid or tau or some other criteria in order to get into that trial, of course that information then is passed on to you when you get a chance to participate. But it depends on what the guidelines for those individual research studies are, and there are many of them, so you just have to ask and be very, get the information to know whether the risk reward for you is worthwhile to participate and satisfactory. And it's not easy, because there are times, I think, where the physicians or medical staff would like to disclose more, but we're simply limited by what's allowed from the regulatory guidance.
I have a lot of questions about white matter disease, or all that white stuff that you saw on the brain MRI that you can see in vascular dementia. And the first question is does severe white matter disease suggest a strong likelihood of Alzheimer's? And unfortunately, it's kind of complicated how they're related. But the way I tend to think about it is that when you have white matter disease, right, you're taking your brain and you're kind of damaging it. And that is an extra layer on top of any predisposition you have to Alzheimer's. So usually what happens is it's not that you just have Alzheimer's. When they do autopsy studies, they actually find a mixed picture where people will have Alzheimer's pathology, those tangles that you see, but they'll also have white matter disease, and that probably compounds the degree of impairment that people have. So when I'm talking to somebody about their brain health, that is modifiable, right? Based on us controlling our diabetes. And somebody asked me about lipids, right? Cholesterol, about our blood pressure. Somebody else asked if we should take a baby aspirin. Oh, that's a complicated question. So it used to be that if you were a male, for heart protection after 65, a baby aspirin was a great idea. And if you were a woman, then after 65, it was great for your brain. Later studies have shown that because of the risk of bleeding, not necessarily into the brain, but in the gut or in the urine, that it's not necessarily such a great idea for everybody, for all comers. But I'll tell you, we don't really know yet about people with white matter disease. We know for strokes, if you've had a stroke, a baby aspirin's a must. But if I just told you that I thought that white matter disease was kind of a culmination of strokes, then it would kind of follow that maybe people with white matter disease should be taking it too. Unfortunately, we haven't done enough big studies to know whether that's the case. So usually what we do is on a patient-by-patient basis, talk about your risk factors and your brain health.
So